Good. Hello, Dr. Vijay.
Hello.
Yeah, shall we start?
Yes, we can start. Yes, can you all hear me? Right. Yeah, very good afternoon. And, so we're going to kind of look at interventions in cancer of the cervix this afternoon, maybe for the next half an hour, and then we'll have the discussion. But what I would like to sort of focus for the first, because the interventions, you have some 6, 7, 8 interventions you could possibly do, but most of them are advanced interventions and not with much by way of effectiveness compared to other sort of cancer pain interventions. So I think what is kind of quite important when it comes to CS cervix is kind of looking at it from a perspective that it's a typical prototype for a mixed pain condition, and if you have somatic, visceral, and the neuropathic components all at the same time, then the interventions are not going to help. And I would like to sort of focus on that actually. So if we look at the cancer pain itself, we have, there is involvement of the viscera, there is involvement of the pelvic muscles, the neural structures due to the tumors, as well as the local recurrences and metastasis. So we tend to get a lot of sort of structures involved with the pelvic pain. And as I mentioned earlier, with the cancer cervix, we get all 3 components together: the visceral, the neuropathic, and the somatic. The somatic component is because of soft tissue inflammation and bone metastasis, which comes in later stages of cancer cervix. The visceral pain is due to the direct of the nerves due to tumor infiltration. And it can also be because of the viscous smooth muscle spasms and the solid organs, the capsular distortion and things, what could happen with it. There might be chemical irritation, which because of the chemicals released from the tumor. There'll be traction, ischemia, necrosis, all sorts of causes why visceral pain should happen. And we also get the visceral pain being referred somewhere else, actually. So it's useful to have that in mind when we are assessing the CS cervix. Because sometimes when we do the celiac neurolysis for the CA pancreas, for instance, it has got reasonably good evidence to do it. But whereas if we do say, for instance, the equivalent of that in the lower abdomen, which is the superior hypogastric plexus neurolysis, it is not kind of documented very well in literature. We don't have any sort of huge studies to suggest that it's fantastically effective. The reason being, the pancreatic cancer pain, it's kind of and you can.
You are not clear.
Yeah, whereas the CS cervix pain is not purely a visceral pain. You get somatic as well as neuropathic components, and that's the reason why the hypogastric plexus block is not well documented and many people won't do it. And then you have this neuropathic pain component as well because of nerve infiltration, and at least 60% of patients with CA cervix tend to present with neuropathic pain. And the most common cause of neuropathic pain, the lumbar sacral plexopathy, is because of the lymph node involvement. And we also get it due to the treatment itself. You have the surgical treatments which can cause the lumbar sacral plexopathy called the neoplastic.
Vijay, I must interrupt. Vijay, for the last minute, you are not very audible. Your volume has dropped very much. We can hardly hear you.
I can hear you well, but can you hear me?
Yes, we can hear you.
Okay. Check.
Yes, Dr. Vijay, please continue.
Yeah, can you hear me now?
Yeah, it's better.
Okay, thank you. So what I was saying was it's a mixed pain, and one of the reasons why the superior hypogastric plexus block doesn't work as well in CS cervix compared with the celiac plexus block in a pancreatic cancer is because pancreatic cancer is mostly it's a visceral component, and doing a sympathetic neurolysis helps. Whereas in CS cervix, it's a mixed pain. So doing the equivalent of celiac plexus, superior hypogastric plexus, and if we do that, it doesn't necessarily help. And the evidence is also pretty poor, and it's very patchy actually. And in addition to that, we also have the neuropathic pain component, particularly the lumbosacral plexopathy, which can happen because of the tumor itself, spreading to the lymph nodes, causing the lumbosacral plexopathy. We can get it, or a person can get it because of the radiation-induced lumbosacral plexopathy, as well as the chemotherapy also causes a lot of neuropathic pain components. So the interventions, say for instance, if someone's got a chemotherapy-induced peripheral neuropathy, there's absolutely no intervention which is going to help that. It's going to be purely a pharmacological management. So not all pains which are related to CS cervix would necessarily be sort of amenable to the interventions. So that's a very important thing. And also, we need to find out say for instance, at what stage the patient presents. If it's a CA ovary, typically it's a silent tumor. We pick it up towards the end, and patients tend to have quite radical surgeries to relieve their symptoms. Whereas CS cervix, they do have some symptoms earlier, and if you're a bit lucky with the screening and things, you might be able to pick it up earlier. And possibly when the pain is still visceral, we might be able to do something about that. Now, we also get bone pain metastasis, for which none of these interventions are going to be of much use. You still have the usual anti-inflammatories, the steroids, the bisphosphonates, and the monoclonal antibodies, the hormonal treatments, whatever not, and the radiopharmaceuticals. And none of the interventions is going to help with the bone cancer pain. And then you have something called the malignant psoas syndrome, which is quite sort of a painful condition which happens with the cervical tumors, where the psoas muscle is involved, and because the lumbosacral plexus runs through the psoas muscle, they end up with their hips flexed and in severe pain. And that's another sort of situation what we face with the cancer of the cervix. The chemotherapy, again, we were talking about certain drugs which can cause chemotherapy-induced neuropathy, which is there are drugs like paclitaxel or cisplatin, and it's quite sort of useful to have that in mind. So I think we'll go to the slides actually. We've been talking about the first couple of slides is what I'm trying to think about the cost. We're talking about whether it's somatic, neuropathic, and it's the prototype of the mixed pain. So this is quite important. And most of the radiation-induced pain or related pain is because of what we call the insufficiency fractures. The pelvic bone fractures which might happen because of radiation, and it causes a lot of pain in addition to the usual sort of cystitis and whatnot you get with the radiation. And what happens is the patient is in pain. You treat them, the pain gets better, and then they start walking, and because there's insufficiency fractures, it kind of fractures again, causing even more pain. So it's something we have to keep in mind. So radiation itself could cause a lot of pain from insufficiency fractures, from radiation cystitis, from the lumbosacral plexopathy, and quite a bit. The lumbosacral plexopathy, typically, if the CS cervix and the plexopathy is because of a lymph node infiltration, then it is quite painful. But whereas the plexopathy is because of radiation, then pain only happens in about 10% of the patients. It's mostly it is a painless weakness which happens in the leg. So that's a very sort of nuanced point which the authors have tried to make. Actually, I picked it up just reading for this presentation. Is present in a very similar manner, not necessarily so. The radiation-induced plexopathies might be more, it will be painless. It's more like a sense, there's a sensory loss of weakness compared with, plexopathy caused by chemotherapy or due to lymph node getting involved. So that's a very sort of fine point actually when we do the assessment. And surgery itself can cause a lot of problems with the CS cervix. You can typically get what we call the chronic post-surgical pains. In fact, this year, the International Association of Study of Pain has declared, till the end of December as the global year against pain after surgery. And we do get a lot of pains after surgery with the CS cervix. And not necessarily because of nerve damage, though we tend to pick up a lot of nerve damage pains post-surgery, post-hysterectomy and whatnot. You also get a lot of what we call the myalgic pains, the pelvic floor myalgia, which is very, very easily missed. I think as doctors, we are very poor actually. The physios are very, very good in picking up the pelvic floor myalgias, looking at the pubic gears, the coccyx muscles, and what actually causes the pain. And typically, what they might need is a true injection rather than higher doses of opioids or other sort of medications. What you could prescribe. Now, before we dive in and we talk about the different interventions, there are certain things. I mean, this is a question which people always ask. What sort of drugs should we stop? When you should stop before you start sticking needles in a person, particularly if you're planning for interventions like an epidural or some other neuraxial intervention. I think there's a lot of noise. There's a lot of noise. Can you all hear me?
Yes, Dr. Vijayanand, but are you changing slides? Because we are only seeing one slide which lists the several drugs on the left side.
Yeah. This is where we're starting. I just got another 5 or 10 actually. So
okay. So I was wondering whether I'm missing the change of slides.
No, you haven't. We haven't actually started it. Okay. Yeah. So what it is when we plan to do the interventions is to kind of look at the drugs which need to be stopped. So this is something which you can have in mind when it comes to anti-inflammatories or the clopidogrel or the aspirin. And once you've done that, we have a list of interventions what you could possibly do. The first one is the neuraxial, which people would kind of opt as a default sort of treatment, which is to do the epidural injections, maybe leave a catheter for longer periods. The next option you have, again from the neuraxial perspective, is to actually leave a catheter in the CSF. So that is something which is not kind of routinely done, but the epidural catheterization is done. The other sort of interventions, what we'll be talking about is the superior hypogastric plexus, the inferior hypogastric plexus, the ganglion impart injection, as well as the neuraxial sort of the intrathecal lysis. So next slide, please. Next. So the cervix, if you look at the spinal interventions, it is T10 to L1. And if by all means it is the superior hypogastric plexus, the presacral nerve, which needs to be blocked to get this to get pain relief. But it only works if the pain is purely visceral, as I was talking earlier. If the pain is a bit of a neuropathic component involved, or if there is a bit of a somatic component involved, the superior hypogastric plexus block is not useful at all. So we have to be very realistic while proposing any of these procedures. Next slide, please. So before we go into superior hypogastric, we look at the more sort of simpler things what we do. I think most or many in the audience will be anesthetists or would have heard about the epidural injections. This is a very simple sort of an epidural catheter which is being threaded into the epidural space, and you can tunnel it and you can use it maybe up to a couple of weeks. So this is quite useful, particularly in end-of-life situations where you want to have a very, very good control of pain. And you can use a lot of medications through the epidural space. I mean, typically what we use is morphine and bupivacaine. We can also use medications like clonidine if someone's got neuropathic pain. And if you're going to run a epidural infusion, you can possibly add clonidine, which works, clonidine being an alpha-2 agonist, it works well in neuropathic pain. There are also a few studies which looked at using ketamine in the epidural infusion, very, very low dose sort of ketamine, which could be used even as an opioid sparing agent when it comes to the epidural injections. The main problem with the epidural catheters is the rate of infection, particularly in India. I think, I'm just taking a wild guess actually, but I think the infection rate is quite high because I do the epidural catheters. The most important point with these catheters is to tunnel them. If you do not tunnel them, then they tend to come out quite quickly, actually. So you got to tunnel them, and there is also some evidence suggesting that if you do the tunneling and you take the catheter away from the site of insertion, then the risk of infection is slightly lesser. But yeah, there is a risk of infection, and when the site of insertion looks a little bit red, I'm always a little bit worried. Maybe we should take the catheter out because of the risk of epidural abscess and cord compression and whatnot. So you've got to be very careful with it. Typically, at least for me, it works up to a maximum of 10 days, probably 2 weeks, and not more than that. And there's always some sort of color changes in the skin, which makes you worried actually with these epidural catheters. These are standard epidural catheters which are used in post-operative pain relief. Next slide, please. And then you can do the spinal catheters. I would like to show the next slide before we kind of talk into it. I think I've kind of misplaced the slide because this is the most expensive option and there's a slightly cheaper option. Now, what it is again, it's a catheter, it's a spinal catheter, which is actually put into the CSF itself and then tunneled. And you can see the diaphragm at the left top corner of your slide. It can be tunneled and it can be placed under the skin, and you can top it up with injections every day. So the risk of infection is very, very minimal, and you can sort of maintain people on this catheter for quite some time, actually. You can leave these sort of implanted catheters for at least a few months if required. And you have special sort of needles which we can use to refill the diaphragm and the catheter, which is available in India. I think it costs something like 30,000-40,000 rupees. I'm not sure how many people use them. I myself personally, I haven't sort of used it in India, but we have used it overseas. It's quite effective. We'll go to the previous slide. This again is another version of the intrathecal catheter. This is a most expensive version of that. I think it's around 4 or 5 lakhs. And there is a big push in India to suggest that we should be using it in cancer pain. I'm kind of very skeptical about this because in all the guidelines which come, it's called the intrathecal drug delivery system, the IDDS it is called. You have this big pump, which is the shiny little thing on the right side, and you have a little diaphragm in the middle. You can fill the pump and you can run the morphine and the drugs what we use straight into the CSF. Now, I'm not a big fan of this, particularly in cancer pain, but there are sort of suggestions coming, particularly from Western countries, that if the pain, or if you think that the patient's prognosis or the survival is going to be more than 6 months, then it is worth putting this catheter in from a cost-effectiveness perspective. Now, spending 4 or 5 lakhs for a cost-effective perspective in India is not possible, but it is there, and I have known a couple of pain physicians who have done this for cancer pain patients who can afford these things and who they thought was going to survive for quite some time. So this is something which is used. It's a very, very expensive option. I personally haven't used it in cancer pain. I have used it in other pain conditions, but not in cancer pain. Next slide, please, and the one after, yes. So this is something which is more straightforward. We kind of looked at the innovation of the cervix, and we knew it was all the lower thoracics, the T12 up to the L1, and to block the nerves, we have to go at the level of L5 S1. And this is a superior hypogastric plexus block. There are multiple versions of these injections. And as I said earlier, we have to look at it with a little bit of skepticism because there is not great evidence to back it up, actually. If it's pure visceral pain, yes, it might work very well. But if it's a mixed pain, it doesn't. So again, I'm kind of repeating my point. Now, the picture you see on the left side of the screen is a posterolateral approach. It's a bilateral sort of injection. Where you go and sit in front of the needle, the tip of the needle goes and sits in front of the L5S1 sort of interface, and they put in contrast. And if you could see a good spread, which is on the right side, spreading on the anterior margin of the vertebral body, then we inject some local anesthesia, wait to see if that pain sort of responds to the local anesthetic injection, and then we follow that up with neurolytic procedures. We either inject phenol, 10 ml on either side, or 7 to 8 ml on either side, or we inject alcohol, which it needs quite a big volume, actually, around 15 to 20 ml on either side. Is what we inject with the alcohol. We also have something called the posteromedian approach, where you go through and through, pierce the dura, go into the disc, transdiscal. There's a single needle which comes out to the other end. And then you can do the same thing. It's a single needle technique. There is a small risk of discitis because you're puncturing the disc as you go along. But it is more, it's quite a straightforward procedure to do. And again, the injection is going to be the same. What we typically do is we inject some 2% lidocaine, diluted up to 10, 20 ml, put it in and wait for 5 minutes, and then ask the patient on table, what his or her pain is like. not his, I mean her pain. We're talking about CS cervix. And if the pain settles down, then we inject the neurolytic solution. And the superior hypogastric plexus block could also be done from an anterior approach through a CT-guided approach or an ultrasound-guided approach. You got to be a little bit careful because we'll be puncturing quite a few viscera as we go along. When we do the anterior sort of approach, particularly, you have to be very careful in asking the patient to empty the bladder before they come in for this particular procedure done anteriorly. And the side effects is pretty much the same with what all the other sort of plexus, the sympathetic plexus blocks. So you typically get the hypertension, the risk of hematoma, risk of pain, for a couple of days after the procedure, hypertension. So nothing sort of different from the other plexus blocks like celiac plexus block. Next slide, please. And this is the inferior hypogastric plexus block. Now, this is a block which we typically do not do, actually, and it is something which is not performed regularly. But there are some literature coming out over the past few years suggesting that it is something we should try. Now, if we have someone with CS cervix, with pelvic pain, particularly at the lower part of the pelvis, then this is something you could think about. And if you have the infiltration spreading lower down, and I mean, we typically reserve the inferior hypogastric for anal tumors and typically lower down organs, but not for CS cervix as such. Here you can see on the left side, the plexus actually sits a little bit lower down. The superior hypogastric plexus is just in front of L5 and S1, whereas this is in front of S2 and S3, just before in front of the sacrum. So what we do is we take a straight sort of, the patient is prone, and we take a straight sort of AP view of the sacrum and identify the sacral foramina. You can see on the left side there is a needle sticking out, and just behind the needle you can see the S2 foramen. Okay, so we enter the S2 foramen from the lateral margin and then keep going till we enter come to the front of the sacral margin just by a millimeter. Now, this is a very, very crucial step. This is a delicate procedure in that for every sort of a tiny movement, we have to keep moving the C-arm, AP, and lateral, because if the needle goes any further than just in front of the sacrum, then you can easily puncture the rectum. It's very similar to the ganglion impar block, actually, because the rectum just sits a couple of millimeters in front of it, and you can easily puncture the rectal wall. So here you can see it has entered the S2, and on the right side you can see the tip of the needle just in front of the sacrum. The dye is spread quite nice in front of the sacrum, and then you do the injection, which you can do the local anesthesia, wait for a while, and then do a neurolysis. And this is not the first procedure which will cross my mind for CA cervix, but it will something which will cross my mind if the usual hypogastric plexus block doesn't work, and if you think there is a spread of the tumor lower down. Next slide, please. I think we kind of spoke about this earlier. This is the ganglion impar block, which is the last sort of tiny sort of knot which sits just in front of the coccyx, and we can use it for CS cervix pain, which is kind of radiating down to the perineum. The approach, what you see on the image here, is a pretty sort of old-fashioned approach where the needle is bent and they go from below the coccyx and go up and to block the coccyx, to block the ganglion impar. I just put this image up so that you can understand the possible sort of problems which might arise. You can see just inferior to the needle is the rectal wall. Actually, it's a very, very tiny space, and you can easily puncture it. And that's the only reason I put this slide up. Next slide, please. Now, how we do the ganglion impar block is quite different. So basically, you choose the sacrococcygeal ligament or the sacrococcygeal joint, whichever you would like to call it. We have 1 and 2. Here you could see the needle at the lower part entering the second sacrococcygeal ligament, and you could see the tip of the needle in the front, and you could see the dye spreading in front of the coccyx. So this is the ganglion impar. So you can do the ganglion impar injection for CS cervix if you suspect that the pain is kind of lower down and there is a lot of infiltration lower down causing CS. Particularly, it might be useful in fistulas and so on and so forth. Next slide, please. Okay, so this is a much more radical approach, actually putting in neurolytic solutions into the CSF, injecting phenol or alcohol inside the CSF itself. I mean, I have to admit, I haven't done one of these for CS cervix, but we have done quite a few for lower abdominal sort of GI cancers, and they work pretty well. It's called, I mean, the anesthetist will understand this quite well. So they put the alcohol or particularly the phenol. They do it. They do something called the saddle anesthesia, where they inject a very tiny dose of local and ask the patient to sit up for a few minutes when they try to do the hemorrhoidectomy surgeries. This is something very simple. If you have the pain in the perineum, then you could ask them to sit up and do the injection to cause the block to come down. Whereas if you're planning to you know, if the pain is higher up in a lower abdomen, then you could think of doing injecting alcohol or phenol. Here you could see the phenol being hyperbaric, it kind of sinks back. So the patient is positioned in such a manner where the phenol is in the dorsal roots. The aim is to cover the dorsal roots all the time, actually. So the patient is actually lying facing the ceiling with a slightly tilt, and then you're doing the phenol injection so that it sinks. The next slide, please. Whereas if you're going to inject alcohol being a hyperbaric solution, it floats up. So if you want to inject alcohol to destroy the nerve roots which supply the cervix, then the patient has to be semi-prone, and the injection has to come from the top and positioned in such a manner it captures the right side as well, not just the dorsal or dorsum or the ventrum of the spinal cord, but also the right side. So you've got to be very careful doing this. And typically we inject about 0.5 ml of alcohol for each level and then wait to see if there is any relief before we do that. It's not like a single shot, you go and put in 5 ml of alcohol and come out. It doesn't happen that way. You've got to be very careful. So this is one option which I have used very successfully in GI, sort of lower GI cancer, in patients who are incontinent, doubly incontinent. They can't, they need a catheter and they need a nappy. So, and they're immobile in bed. So they have a few weeks to live and they're pretty much flat, and they need assistance with their toileting and whatnot. So that's when you do it, because you invariably destroy the nerves supplying the bladder as well as the bowel as well as the legs, which means they're going to be paralyzed after this procedure. So if they're already bedbound and pain is the only problem, this is something which you can think about. I think that's about it. I have for today. Next slide, please. Thank you. Yeah. So I think what I'll do is I can take questions actually. Sorry for the sound quality. I don't know what's happened. I don't know if it's my side or the other side, but.
Okay, Dr. Vijay. Anybody has any questions, Dr. Vijay?
Good afternoon, sir. Hello, am I audible, sir?
Yes.
Hello.
Yes,
okay.
You are audible.
Sir, very nice to hear your presentation, sir. A very good topic, and CS cervix is very common, and I have seen patients, so many patients dying with severe intractable pain, and where morphine does not work and other drugs does not act. Sir, I have one question, sir. I just actually could not catch up with you regarding the neurolysis, what you have used for the lower GI cancer. How much ml you inject per space? What is the actual procedure for doing it, sir? Can you please explain it once again, sir?
Yeah, sure, we can do that. See, this is lower GI tumors, particularly the rectal tumors, which is quite painful towards the end of life. And these are the patients who have very poor prognosis, have maybe a few weeks to live, not more than that, who have no control of their bladder or bowel, and who are bedbound. Now, these are the three conditions the patient needs to satisfy before we start putting needle inside the CSF and start injecting neurolytic solution. So what we do is we sit the patient up. We go in the midline, just the normal spinal, we use a large bore spinal needle. We go in because the phenol is very, very viscous and it's tough to inject. And all it needs is 1 ml of phenol. So we put in half a ml. It is not particularly painful injecting phenol because you might know that it has the local anesthetic properties as well. It is not painful injecting phenol. So do the spinal, wait for the CSF tap, and then inject half a ml of phenol. Wait for that to sink in, and maybe the patient might need another half a ml of phenol, and that's all it is. And we ask them to sit up for a good sort of 20 minutes, half an hour, so that the neurolytic solution is fixed on the sacral plexus, which supplies the lower part, the S3, S4, and all those sacral plexus. And then the pain goes away. Within 10-15 minutes, the pain disappears. And I don't think anyone knows how long these procedures work, because we are kind of typically offering these procedures to patients who have a few weeks to live, actually, and quite successfully too. The pain reduces, but obviously there is going to be motor weakness in the legs.
So, Dr. Vijay, just to repeat, incontinence, bedridden, and one more thing that you emphasized before you would consider spinal analgesia?
Bowel control.
Incontinence, bed bound, and third one is?
Bowel.
Bowel only, okay.
Sir, hello, sir. Hello, sir.
Yes.
Does it cause much pain while injecting, sir? I don't have any experience, because I had experience with alcohol, sir. When I inject alcohol, it causes much pain. So you did not give any local anesthetic.
Yeah. See, phenol, typically we don't give any local anesthesia because phenol itself has local anesthetic properties. But if we inject alcohol, we always give local anesthesia. In fact, when we do all the sympathetic blocks like the superior hypogastric or the ganglion impart, we do the local anesthetic for two purposes, actually. One is to sort of, for the patient to tolerate the alcohol injection later well, because it will be followed up with the alcohol injection. And primarily, we use it as a diagnostic as well. So if we do a superior hypogastric plexus block, put in some local anesthesia, and the pain disappears, then we can be reasonably sure that if you're going to inject neurolytic after that, then the pain relief is going to last longer. So it's kind of used diagnostically as well as therapeutically. Actually, if we're going to plan to inject alcohol, almost always we inject local anesthesia prior to that. And almost always we tend to avoid using alcohol in the neuraxial plexus, actually, because for me, it's a personal choice. I know people use alcohol in the epidural neurolysis as well. But for me, I don't think I have a scientific reason why I do that. But phenol, I'm quite comfortable with phenol, actually, when we're doing the neurolysis, neuraxial. So if you want to target one specific nerve root, then you put the needle close to that nerve root and inject the phenol and kind of lie them accordingly, which is typically sort of lie them in a way that the phenol sinks to the dorsal root or the same side which you want to destroy. Then that's much easier. I somehow think that I don't have good control of alcohol. Yeah.
Thank you very much, sir. Vijay, sir. Thank you very much.
Can I?
Dr. Mary.
I just wanted to know what % phenol do you inject, Vijay? 6%? What percent phenol? Is it 6 or 10?
6% phenol, ma'am.
6%.
6%.
Dr. Vijay, when we have a catheterized patient come back to us after the intervention pain management person has put in the catheter, can you just tell us how to maintain it and what are the precautions we need to take before injecting, giving each supplementary dose, etc., to ensure that it's in place and it's not infected, etc.? How to maintain a catheter?
This is something which I've always struggled, actually. I mean, there are two different things we'll talk about. One is the epidural catheter itself, and the next one is the spinal catheter. So the principles are slightly different, though in terms of keeping it free from infections is pretty much the same, but in terms of maintenance is slightly different. So if we put in an epidural catheter, which commonly we all do, and we send the patients back home sometimes, the first important point is to tunnel the catheter. So unless it is tunneled, it quite easily it comes out actually. So it is very, very important to tunnel it, and then have a decent dressing. And one other thing, particularly with the epidural catheters, particularly in cancer pain, is these patients are pretty emaciated, and we have to give a good padding when we cover up the epidural catheter. Otherwise, I know it's a tiny tube, but it keeps digging into the skin and causes a lot of damage to the skin itself. So a nice padding and a support. And then it has to be checked, if not every day, at least alternate days. Someone in the family has to be trained just to sort of remove those dressings to see if there is anything there. Typically, we ask them to see if the catheter has come out, or we kind of tell them the markings. You know, if it is marked 2, it is 10 centimeters. If it is marked 1, it is 5 centimeters. So just kind of keep an eye on that. Look at the skin itself to see if it does look red, or if there is any sort of fluid which looks like pus which is coming out, and then put it on. We don't ask them the family members to clean the area. Because they could quite easily pull it out. So we just ask them to have a look at it, maybe change the dressing and just leave as it is, not to clean it with the betadine or anything like that. And then typically we would like to see them in a week's time, by which, most of them have some problems with the catheter. With epidural catheters, they always tend to migrate. They kind of, you think it is sitting in the midline, whereas it might kind of gone into one of the foramen and have gone out, and they might have some heaviness in one particular dermatome, myotome, and then they will be completely sort of having a lot of pain on the other side. So we always had this problem with the epidural. So we ask them to come back in a week's time to do a bit of troubleshooting. And the catheter, that's all we do actually. And when they come to see us, then we kind of look for pain relief. We look for, because typically with the epidural catheter, we use very low concentration local anesthesia. You use kind of 0.01 to 5% bupropion. So we look for motor weaknesses, if there is any. We also look for a good quality pain relief. If there is motor weakness, then that kind of keeps the alarm bells going, because whether it's infected, whether the patient's got an epidural abscess, whether there is a compression on the spinal cord, and this is the red flags which we look for. So infection is something which is very, very high in our sort of list when we do these catheter techniques. When it comes to the spinal catheter itself, it is you've got to be very, very careful actually, because in the spinal catheter we don't typically inject a big volume of local anesthesia. We use a tiny, tiny volume of local anesthesia, which is mixed with morphine actually, because we think it is the morphine which is helping. Because you put local anesthesia in the CSF, they're going to drop their blood pressure if you put a spinal catheter. So we use small doses of morphine, maybe 1 milligram, and that would kind of last for a good 20-24 hours actually, morphine injections. And we kind of train them to do that. Typically what we also do them, because there is the morphine, that tiny bit, 1 milligram, it actually stays in the catheter itself when you inject it through that port, which means the patient's not going to get benefit. So we typically ask them to flush it with sterile saline after they inject the morphine into the catheter. The implanted catheters for morphine, they kind of quite long lasting. But we have to be very careful because they might not be sufficient, and the patient might still be tempted to take oral morphine with this thing. And we also got to be very careful with the conversion as well, because with the intrathecal morphine, it's 100 oral dose. So if someone's taking 100 milligrams, you give them 1 milligram intrathecally, and that 1 milligram will last for a good 24 hours. Otherwise, the looking after bit, it's pretty much the same. And there are special needles which are kind of bent in right angles to puncture the diaphragm, which is implanted in there. There is titanium filters as well. So those needles, we have to sort of suggest the patient that they shouldn't be reusing it, and make sure it is kind of cleaned very well. And sometimes what we do is we put the needle and then keep the needle in, sometimes locked, so that they can use it as well. So there are multiple ways of doing with it. But the most important thing, or the thing which would worry me most, is what happens if this gets infected. So if there's any call in the midnight asking, will it be this, will it be that, the first thing which should cross my mind is whether I should pull this catheter out. So I think we should be ready to do that at the drop of the hat, actually, because that's something which really is a worrying thing. Okay. Now, yes.
Yes.
I wanted to ask about the volume of alcohol which you inject. You said 1 cc of phenol. what about alcohol?
Alcohol, I don't inject into the CSF, actually. I don't inject into the CSF. Typically, we don't. Because alcohol tends to float if you're going to, I mean, sterile anesthesia is not possible with the alcohol, it floats up. But you can target the nerve roots and you can do the alcohol injections. That is possible. There we use 0.5 ml of alcohol for every level.
Yeah.
Not on the spine, not spinally, but yes.
So I have received.
Yes. There has been a question with regards to antibiotic protocol. You know, if you're going to leave catheters in, you know, how long you've got to give antibiotics and things like that. Now, typically when we put the spinal catheter, we give the first shot of antibiotic prior to the insertion of catheter, which is a gram of cefotaxime. We do the catheter. It's got to be a third generation cephalosporin, and that seems to be the standard protocol everywhere. Even if you're going to put implants in, that's what they do. And so the first dose goes prior to the catheter insertion, and typically the microbiologist recommends, you know, just give them 3 doses after that. So they be converted into oral, and they kind of start them on some oral medications.
I have received a few questions for carcinoma cervix. So one is there any role for interventional pain management in vesico-vaginal fistula or rectal vesical fistula? Because it is very common to see these problems and patients complaining of burning pain, and quite difficult to manage this pain. So
yeah, I mean, it's a good question you asked. I mean, I do not typically see these patients actually. I mean, what kind of pain do they complain when they come with vesico-vaginal fistula?
they usually complain of burning pain. It
is a mucosal kind of burning pain. Yeah.
Burning sensation, isn't it? Yeah. Well, the thing is, if it is visceral, and it depends on which level. I mean, if it's quite lower down affecting it, then you can possibly try some you know, superior hypergastric or a ganglion implant injection. I wouldn't say it's a definite no-no, but I mean, I do not have any personal experience in offering patients this interventions for this particular problem, particularly the fistulas, the vesico-vaginal and the rectovaginal fistulas. So I don't think I'm the right person to answer the question, but yes, because you can try that. If you think it's visceral pain, it's coming from the mucosa, from the viscera, then it's something you could think about, yes.
And another question is, it's usual to have lower abdominal, pelvic, perineal pain and backache radiating down both lower limbs. So this is one question that I received. For any intervention can help. The backache.
Sorry, I didn't get your question. Backache, yes.
Yeah, backache, perineal and pelvic pain, which radiates to the both lower limbs.
Both lower limbs, right. Yeah, this is a typical presentation with patients who come with CS cervix. I mean, it's kind of going back to what we were kind of discussing or talking about earlier. It is going to be a mix of not just the visceral pain, it's going to be a mix of neuropathic as well as nociceptive pain. And I think it is the pharmacological management which is the first and foremost, particularly when it comes to CS cervix and kind of diffuse pains all over. So you treat them with the neuropathic pain medications, you treat them for the nociceptive pain with the opioids and anti-inflammatories and whatnot. And if the pain still doesn't settle down, is when we will start wondering whether an intervention might help. Because the reason I'm saying this is, see, if it is CA pancreas, I would say, well, I would offer my celiac plexus block even before we can start morphine, because the earlier we do it, the better. Whereas we do not have that kind of evidence in CS cervix to suggest that if you do a sympathectomy, either with a superior hypergastric or an inferior hypergastric, it doesn't necessarily, you know, reduce the opioid requirements, because the evidence is much lesser. So I will use it as a last resort, actually, before start sticking needles in. And depending on the distribution of the pain, I might try some different things. I'll go for the least neurolytic or the least complex procedure first, and then we can increase in complexity as we go along. And the thing is, you can it's kind of weighing the options. Epidural is the easiest thing to do. you can do the epidural catheter insertion, but that also comes with the usual sort of risk of infection and things. So if you're a chronic pain consultant, I think for me, I would think just sticking a needle and injecting alcohol, getting rid of the pain and moving away without any sort of catheters hanging out is a better option for me. So I think it depends on the kind of skills available in your place, and it also depends on what kind of follow-up we can organize. Because if the place has someone to follow up even at night time, then it makes sense to put in catheters and follow it up, because typically they go to bed, they kind of roll in bed and the catheter comes out and it stops working, and then you get the call in the middle of the night asking whether we should bring the patient down to the hospital. So if you have that setup, then that's a better thing. So I wouldn't say one is better than the other. I wouldn't say I would try this rather than this. I think it depends on what typically the center offers and what we are trying to do.
So Dr. Vijay, since the catheter coming out is such a common possibility, what would you suggest as the right appropriate dressing? Suppose the catheter is not tunneled. You of course emphasize that tunneling is the best way to keep it stable. But in case the patient comes to us without tunneling and patient has good pain relief, how can we ensure that it lasts as long as possible? What is the dressing that you recommend?
Yeah. Just the name escapes my mind actually. They have this, I don't know how it completely, it's just gone out of my mind, is that spray thing which helps sticks the catheter to the skin is quite helpful. We can use those, there are some really nice Mepo dressings which can fix the catheter quite well. You'll have to roll the catheter so that there's a bit of tug so that it doesn't come out. So there are a few techniques what we do, but none of them are, it gives you 100% guarantee that it won't come out. I mean, some people even stitch catheters in, like a loop, and then leave the catheters in. But it doesn't mean that the catheter won't come out, because there are always sort of novel ways to pull the catheter out.
Okay, thanks.
Thank you, sir.
Please ask once more. You are not.
Yeah. Is there any evidence to show that the dose of requirement of opioids reduces if we give a superior hypogastric block?
None at all, actually, none at all. And this is the reason, this is the thing which I've been reiterating right from the beginning, because CS cervix is if you have one pain, which you can use it as a prototype for mixed pain condition at CS cervix. So you get a mix of everything actually. The superior hypergastric might help with the visceral pain, but it doesn't do anything to the neuropathic or the somatic pains which the patient might have. So there is absolutely no evidence in celiac plexus. Yes, there are some evidence that the opioid dose might be lesser, not with superior hypergastric. No.
Thank you, sir. And Dr. Amrita will be doing the case presentation for today's session. Good afternoon all. I'm Dr. Amrita from TIPS, presenting you with a patient scenario that has been sent to us from a center which was not able to connect today. We have a 55-year-old woman who presented with carcinoma cervix with bone metastasis and abdominal lymphadenopathy. Her presenting complaints was lower back pain and left lower limb pain. She was unable to walk independently. Her pain presentation was, she had pain, lower back pain as well as a pain in the lower limb. That was a throbbing type of pain that was only on sitting and standing, and was relieved by lying down on right lateral position. There was no radiation to the abdomen, and the pain score was 9/10. And her lower limb pain was a burning type, which was continuous and was relieved with morphine. The pain score from 9/10 decreases to 6/10 with morphine. So the patient history says that she was diagnosed carcinoma cervix in 2015 and had taken radiotherapy and chemotherapy, had a recurrence with bone metastasis in August 2017, for which she underwent 5 cycles of radiation, 5 fractions of radiation. MRI was repeated in August 2017, which showed collapse compression fracture of L3 vertebrae body with diffuse marrow edema with posterior bulge of vertebral body indenting on the theca, causing mild bony canal stenosis. Psychosocial history. She knows that she has cancer of cervix and spread to the spine, and she hopes that she will be able to work. She lives with husband, son, and daughter-in-law. They are very supportive and helps her in her area. Patients don't want to depend on others, and they are financially stable. Her medication since the last 3 months, she's on TAP morphine, 5 mg Potali, etoricoxib, sodium valproate, she's on sodium picosulfate, clonazepam, and Pandol. So the problems or the challenges which the team was facing was that patients don't want to take medications. It was not because of any fear, but she was not willing to take any medications. She had some pain relief after the radiotherapy for 1 month, but increased after that. And in between, she stopped taking medications. So the concern arised by the team, can any interventions help her, as she was not willing to take any medication?
Okay. Can I answer that question?
Yes, sir, please.
Yes, okay. See, we are looking at 2 components to a pain. I mean, typically what we were discussing earlier, there is the back pain, which is kind of mechanical in nature, because it is typically brought about by sitting, standing, the activities. It is not there all the time. So that's the back pain. And then you have the leg pain, which there is a burning, continuous quality to it, which means it's got a neuropathic component. So there are 2 things. Now, if you look at the back pain itself, it could still be a visceral pain which is referred to the lower back, actually. Okay, that's one possibility. Because typically pancreatic cancer pain presents as a mid-thoracic or sort of upper lumbar back pain. So it could still be a referred pain, or it could be because of the vertebral fracture, the L3 fracture, which is sort of indenting the cord. So that's 2 possible reasons for the back pain. One is the CA itself kind of causing referred pain, or it's because of the fracture vertebra. Now, the leg pains, what she's having, again, there could be 2 possible reasons. One is the fracture itself, possibly pinching the neural foramen, causing this shooting pain going down the leg. And the second option, because she's got this abdominal lymphadenopathy, it could be the lumbosacral lymphadenopathy, lumbosacral sort of metastasis, which is causing the lumbosacral plexus to be pressed and causing the pain going down the limb. So this is something which, there's a lot of permutations and combinations why this pain should happen. And I mean, in terms of interventions, I think I would like to be a little bit more clear in my own mind. Say, for instance, the back pain is mostly because of the vertebral fracture. Then you could quite comfortably do what's called a vertebroplasty, where we go into the pedicles, put some PMMA cement, which is the polymethacrylate cement, and that tends to help with your pain. But the big question is, how will you differentiate between whether it's a cervical cancer itself causing referred pain, or whether it's the fracture vertebra causing pain? So, and both these pains typically they respond to opioids as well. But if my medical treatment is optimized, she's on a good dose of morphine and all the neuropathic pain medications, then I would give the vertebroplasty a go for the back pain only. So sometimes, not always, sometimes it might help with the neuropathic pain. But there is another version of that which is called the kyphoplasty, where you actually go in and then inflate a balloon to pack it up, and then you could sort of inject the cement in there, which kind of regains the height, and if there is a mechanical compression, that it might. So that's one intervention you could think about. And the second option, what could possibly you could possibly do is, if you're thinking it's a visceral pain which is radiating in the back, is to think about in terms of superior hypogastric plexus block. I think Dr. Nandini made a good point. So examination might help you. So if you have back pain which you don't know whether it is coming from the spine or whether it's coming from the pelvis, you could palpate. If there's a gibbous, there is a deformity in the back, then obviously it's the fracture. And if there is tenderness, because if you have pancreatic cancer radiating to the lower back, pressing the back, you won't typically have any tenderness in the lower back, actually, because the pain is all getting radiated from the abdomen. So a very similar picture you will have with the pelvic sort of organs as well. So that's a good point which was made. So yes, so this is what it is. Now for the leg pain, you can do, if it is just a simple neural foraminal compromise because of the fracture, you could try some transforaminal injections which might help with the pain. But if it is because of the lumbosacral neuropathy, then there's a big challenge there, actually, because it typically kind of runs within the psoas muscle, and I typically don't get good results doing interventions in lumbosacral plexopathy because it's a large area to be blocked. You can still do a lumbosacral plexus block by going into the psoas muscle and injecting some local anesthetic, maybe put in some steroids, but it might be very short-lived, actually. It won't give them good benefit. And again, it has to be balanced against doing something neurolytic for that particular leg and losing the motor sort of component of the leg. So that's a tricky bit there, actually. So I'll be very careful doing any interventions in this particular lady. If there is a tenderness, if there is a gibbous, if I think it's the fracture L3 which is causing the pain, then yes, you have good value for money for the vertebroplasty or the kyphoplasty. But all other interventions, what I'm talking about, the superior hypogastric plexus, the transforaminal injections, the lumbosacral plexus block, you wouldn't get good value for money. So yeah.
I wanted to ask, why is this patient on etorocoxib to the team?
No, actually, this is not our patient. But this case history was sent by another person who is unable to connect to them.
So maybe we should open out that question also to the group, no? So that we rationalize the prescription of what is going on. We could look at the pain and ask this group of team members who have joined in as to what all is right with the prescription and what all could be improved. That could be a good exercise for learning today. I was just wondering.
Dr. Sashala?
Yes.
Do you want to comment?
I want to ask a question that what can be done in a very low resource setting? I mean, we talk about vertebroplasty and all, but if it's a low resource setting, what would you go for in such a patient? Would you just rely on pharmacology or do some interventions?
Yeah. I think pharmacology is the way to go, actually. We've been talking about it's more than low resource. The vertebroplasty is a very, very cheap procedure, actually. It only needs a vial of cement and it needs a bone marrow biopsy needle, the Giemsa needle, and that's all it requires for a vertebroplasty. Though in private corporate hospitals, they may charge an arm and a leg. It doesn't cost much at all, actually. It can be done in a low resource setting. The big question is whether we have the skills to do that in a low resource setting.
Yeah.
It is not expensive, but it needs the people who are skillful enough to do that, actually. So if you do not have that, then it is an issue. I think it's going to be a straightforward pharmacological management, because all these procedures, what we're talking about, the intrathecal, the epidurals, the superior hypogastrics, I mean, these are things which are quite sort of it doesn't not only require skill but also a lot of backup required. And if it is not available, it is not worth venturing into all these things.
Madam.
Can we see like Nandini said, if we can look at the prescription again, then maybe we can see how better. So can we project the slide of the prescription? Okay, what I wanted to ask is, can the morphine be stepped up? We are giving only 5 milligram Q4H. So would that help? That's what I was just wondering. Along with paracetamol rather than etoricoxib.
I think what they've kind of tied their hands in saying that this lady doesn't like any medications.
Yes. Oh.
Right. The person who sent us told that she doesn't want to take medicine and she needs pain relief. So that's why the person was asking us whether interventions would help this patient. But it is for us, it is better to discuss the possibilities that can give pain relief. Definitely, I think because this patient doesn't have delirium or myoclonus or toxicities of morphine, definitely we can increase the dose of morphine. That's one option.
I think there's still a lot of medical optimization we could do with that list of medications, actually, for the neuropathic pain as well as for the somatic and the visceral pain. There are a lot of things you could do with that prescription. Maybe, I mean, it's worth kind of exploring why she lost confidence in the medications. I mean, because that dose is pretty tiny for a 55-year-old with an advanced CS cervix, and also the neuropathic pain medications, we still have to sort of work around that. Maybe the optimal dose, she might respond better and she might be more compliant or willing to continue with the pharmacotherapy rather than interventions. I mean, if this was my patient who walks into the door, I mean, I would convince her to get these medications optimized. And if it doesn't help, then we can think about all the interventions and whatnot. But if there is affordability and if the patient can because it's a multi sort of pain condition, which I think it's kind of somatic neuropathic. If one intervention I would like to choose, which is going to give better value for money, it will be citing an intrathecal catheter with a port in the chest, so that I can top it up with medications if required, because that could be long term actually.
Yes, madam.
Yeah. Supposing we can't do a vertebroplasty, would a lumbar brace help? I mean, I'm just saying in case it cannot be done. Yes. Would that kind of support the spine and give some relief, a proper brace?
Yes, yes. I mean, there are two components to this, madam. I'll first talk about vertebroplasty itself. There are a few sort of unknown things with vertebroplasty. The guys who do that swear that it is the best thing, but there is a lot of things which has come under question. For starters, we do not know how a vertebroplasty works. Why that should relieve the pain is the first question. I mean, no one can sort of can kind of explain to it. The current thinking is you put in the cement, it's an exothermic reaction, so it emits heat and it destroys the nerve in the vertebral body, and the patient loses the thing. And then there is a long-term follow-up saying that it's not any better than just putting a lumbar corset, which Madam was talking about. And the things like vertebroplasty should be avoided because it doesn't have a long-term sort of effectiveness. So what Madam mentioned was very correct. If there is no option to do a vertebroplasty, a corset might help, because say still about 15-20 years ago, we did not do that many vertebroplasties or kyphoplasties. And the only treatment available was bed rest and a corset, so that the fracture heals by itself. Yes, you will have a slight deformity, a kyphotic deformity post-healing, but that is kind of it's kind of by and large okay with the population. But there will be pain. Even with the corset, they will still have the pain. But it is something which could be recommended, actually, cause it with the rest. Yes.
If the number of tablets is an issue, of course, after optimizing the dose, as Dr. Mary was suggesting, we should step up and find out the right dose for the opioids, understand the right non-steroidal, and also look at the neuropathic medications. But once we know the dose of 24-hour dose of morphine, we could consider making it into a sustained release so that the number of tablets go down per day. And also, instead of sodium valproate, if we use amitriptyline, it could again become once a day. And clonazepam with sodium valproate, both are they for neuropathic component? I don't know. Those kind of modifications and evaluations may help. And of course, if the patient is affordable, we could use a patch for the continuous pain relief. So that if just it is the tablets, we could discuss with her what is the problem and respond at least partially to her issue of taking tablets. The basis would be need a physiotherapy consultant, Dr. Vijay, or if there are, there are these, people they don't understand sometimes the difference between a lumbar belt versus, the brace. So one is very, very rigid, isn't it? So if you could just give a few points so that it's learning. Yeah.
Very uncomfortable. Very uncomfortable. Yes.
Yeah, it's very uncomfortable.
So one of the problem the doctor reported was the patient and the doctor, they lives far away, approximately 300 kilometers away. So the patient doesn't have a proper follow-up. Once the patient goes, then the patient comes for follow-up once in a month. So by the time the patient will stop taking medicines, and then the patient will reach the hospital, that doctor will try to again to restart the medicine. That's what happened as per him.
So then getting her connected to a team where she can replenish her medications before her supply finishes could be an option, because her frustration with tablets could have been because each time it runs out, she's getting pain and then she has to travel with pain to the center, etc., etc. So connecting her to a nearer center or some home care service where she receives the medications more easily could be another way of handling this situation. So if the patient asks for the intervention, it may not be an intervention, indication for an intervention. It may be an indication for further communications, I think.
Mm-hmm. Okay. So another question, not regarding this, but generally, radiation proctitis is one question that has been sent for discussion during this session. So, how many of you are using any methods, or what do you commonly do to treat radiation-induced proctitis and pain?
You ask me, Sunil, the question is for me?
For the group.
See, radiation proctitis is not something which we kind of deal with day in and day out. It's normally taken care by the palliative care physicians, because I think there are better people than me to manage that. But I think if you ask me what would you do from an interventional perspective for a radiation proctitis, I will try something like a ganglion implant, just a simple local anesthesia injection to see if that helps you. Just put some bupivacaine which lasts for 4 or 5 hours and then see if that proctitis pain reduces. If that reduces, then you can think in terms of doing a neurolytic procedure. But that's about it, actually, because I don't think I have great answers for that. Otherwise, it gets more and more complex, actually, to treat that. I mean, opioids is another option. I think, as I said, this is not something which I am kind of experienced looking after.
Okay, steroid retention edema is the one which commonly prescribed for radiation-induced proctitis. So, anybody has any other comments on radiation-induced proctitis? Dr. Iqbal?
This radiation-induced proctitis, it happens patient who survive cancer basically. Those who get CA cervix, and this is one of the long-term complication of CA cervix. Yeah, the CA cervix, you don't find any primary, then you get a complication of radiation proctitis. Usually, what you say, we also use hydrocortisone enema, that is retention enema, small amount of liquid, so that the patient can hold in the rectum. And also sometimes we use sucral fit anemia, sucral fit, and also we can mix sometime lignocaine to get a very good pain relief. But the most important one another the problem is then patient has tend to have radiation induced proctitis bleeding, and that has to be confirmed by a doing a proctoscopy to see whether there is rectal infiltration or it is a rectal proctitis. So we have to take a biopsy sometime to prove that it is radiation induced proctitis and not a radiation. And if the patient is having severe bleeding and it is not being controlled, so surgeons perform a bypass. They do a colostomy and give rest to that part. Other because each time she passes stool, that ulcer do not heal because it is a continuous process each time. Well, so they do a colostomy, they do bypass, and it takes some time, and the proctitis part heals. This is the way we manage this patient in our hospital. Yeah, we usually, Nandini madam, we dissolve 100 milligram of hydrocortisone in 100 ml of normal saline, and we give we train our the attendants to give 5 to 10 ml of retention enema 2 to 3 times per day. Yeah, sucralfate we don't mix because we just take 5 to 10 ml of sucralfate, and we does not make don't make mix with hydrocortisone. That is, if we give hydrocortisone 8 hourly, so in between we give sucralfate enema because the patient cannot retain 10 ml of hydrocortisone not more than 30 minutes or 40 minutes. So in between we give sucralfate enema. This is undiluted, 5 to 10 ml of sucralfate.
So what position do you give, Dr. Iqbal, after the enema is put in? How would you make the patient hold it long?
Yeah, we tell the patient to stay in the supine position or in the left or right lateral position to hold it. That's the thing, to hold the enema.
The amount of enema should be minimal.
This is, yeah, this should be retention. Yeah, this is small bowel. If you give more, there will be a colocolic reflex and it will distend, it will come out. So you have to give small amount so that the patient can hold it. This is the main idea. Thank you, madam.
Pain due to obstructive uropathy. So, how can it be managed? That was another question sent to me.
Hello, Dr. Sunil.
Yeah.
Can I answer this question?
Yes, please.
Yeah, in obstructive uropathy, Sunil, Dr. Sunil, the patient don't complain of much of pain.
Hmm.
If there is obstructive uropathy, this comes as a stage 3B cervical cancer. So if it is a stage 3B and if the performance status is very good, the patient is young, and if the renal parameters are very much decompromised, then sometimes percutaneous nephrostomy is performed. And after that, the patient gets radiotherapy, that is the curative treatment, radiation chemotherapy, if the renal function gets settled down. And it is sometimes seen that with this percutaneous nephrostomy, sometimes the patient gets very good response after chemo RT. But where if there is patient is very much frail and patient is less likely to survive for few weeks, and there is other metastasis, visceral metastasis, so it is not advisable to correct the obstructive uropathy, because it has been seen that uremic patient tends to die a very painless death. So it is better not to do a percutaneous nephrostomy in this, and the requirement of opioid and other drugs decreases. Only thing is that patient has some delirium, which is very much well controlled with slow doses of haloperidol. Thank you very much.
Anybody has any comments? Dr. Manoj? Yeah.
Hello, Dr. Manoj from Bangalore.
Yeah.
This is a question to Dr. Iqbal. They don't try the conventional DJ stenting to relieve the obstructive uropathy. Is it not possible? Because when I worked in my earlier institute, they used to first try the conventional cystoscopic procedure to find out whether they can access the ureter, and then they would finish off the procedure within 5-10 minutes before actually going into percutaneous nephrostomy.
Definitely, sir, you are right, sir. DJ stenting is very much commonly performed.
Yes.
But in sometimes, sir, where there is no facility, suppose as such we did not have any facility of DJ stenting, because we need a cystoscope, and where you need so this is the one problem. And, and PCN is very much easily can be done, sir. It can be just with the help of ultrasound, you get to see the cortex, you'll see big inflamed kidney. Just put it is very easy, sir. And once the lower part resolves, sir, you can just take it out, and the distal part obstruction release, it will settle automatically, sir. But definitely, sir, in cases where there is retroperitoneal fibrosis, there is post CTRT stricture, definitely the choice will be to put a intravesical, I mean that DJ stent, sir. You are right, sir.
Thank you so much. Thank you. Yeah.
Thank you, sir.
Any more comments? Any comments?
ಆಮೇಲೆ ಕೊಡ್ಲಾ?
If there is Dr. Vijay, are you still there?
Yes, I'm still around. Yes.
Okay. Do you have any comments to make so that we can close the session for today?
Not really. I think there are a lot of good points to discuss. I mean, for me, it's a big learning experience, particularly the points which Dr. Iqbal's been making about the obstructive uropathy and all the other conditions. So, not really, not from an interventional perspective.
Okay, then let's close this session today. And thank you, Dr. Vijay, and all the others who joined for the session today. And next session is on intervention pain management in carcinoma of the pancreas and chronic pancreatitis. that will be led by Dr. Sushma Bhatnagar. And Dr. Vijay have one more session in January for interventional pain management in head and neck malignancies. Thank you.
Thank you.
Thank you, Dr. Vijay. It was a wonderful session. Looking forward to seeing more. Thank you very much, all the team. Thanks, Sunil. Thanks, Sunita.